Welcome to the introductory briefing of the National AVBC Stroke Collaborative. In this video, we will explain how the collaborative fits within the broader AVBC agenda, walk through the collaborative journey and timeline, and introduce the driver diagram that will guide participating teams. By the end, you should have a clear sense of what the collaborative is trying to achieve, what teams need to prepare, and how we will learn together across institutions. Today's virtual introductory briefing on 2nd of June 2026 is an important starting point for participating teams, but it is not the beginning of the collaborative journey. Before today, several preparatory steps have already taken place. These included this evidence scan, ground sensing with value offices, the pre-session survey, theory of change co-creation and synthesis, validation and endorsement. This preparatory phase was important because we did not want the collaborative to begin with a vague problem statement. The aim was to move from a broad national priority to a clearer shared understanding of stroke care pathway, the implementation context, and the areas where teams can realistically act. From today, the work shifts from national preparation to team preparation. The next major milestone is Learning Session 1 on 10th of November 2026, followed by action periods, virtual group calls, Learning Session 2 in May 2027, and Learning Session 3 in November 2027. So this timeline shows the full arc of the collaborative, from system-level preparation to a team-based testing to shared learning and eventual synthesis for spread and scale. Today's briefing gives everyone a common starting point. It clarifies the purpose of the collaborative, the overall timeline, the expectations ahead, and the preparation needed before Learning Session 1. Before now and Learning Session 1 on 10th of November 2026, each institution should begin forming its local project team and prepare the basic building blocks of the improvement work. This includes clarifying the local aim statement, reviewing baseline data, mapping the current care process, developing a measurement strategy, and selecting relevant change ideas. This preparation matters because Learning Session 1 is not meant to be the point where teams start from scratch. By then, teams should already have some understanding of their local problem, their current workflow, and the part of the national driver diagram most relevant to their setting. After Learning Session 1, teams enter the first action period. This is where the change ideas are tested through PDSE cycles. The goal is not to launch a perfect solution immediately. The goal is to test on a manageable scale, review the data, learn quickly, and adapt. The virtual group calls between learning sessions will act as structured check-ins. They give teams a chance to share progress, discuss challenges, compare learning, and maintain momentum between main learning sessions. Learning Session 2 in May 2027 will bring teams back together to review early learning and refine their approaches. The second action period continues towards Learning Session 3 in November 2027, where teams will share what has changed, what has been learned, and what may have already for sustained and spread or scale. The key message is that learning sessions are not isolated events. They are anchor points in the longer improvement journey. The real work happens between them, through testing, measuring, learning, and adapting. For the driver diagram, the key starting point is the aim, to reduce acute hospital length of stay for ischemic stroke patients. But it is important to be clear about what this means. The aim is not simply to discharge patients faster. The real improvement question is how we make care more reliable, more proactive, and better coordinated so the patients receive the right care, at the right time, in the right setting. The driver diagram is organized around 3 primary drivers. The first primary driver is appropriate short stay management with timely disposition decisions. This focuses on identifying suitable patients early and making key disposition decisions within the defined time frame. For example, teams may test short-stay stroke pathways through an emergency diagnostic and treatment unit or acute medical unit model, with risk-stratified eligibility and fixed disposition decisions by 24 or 48 hours. The second primary driver is proactive discharge-oriented inpatient care. In practical terms, this means discharge planning starts early, not only when the patient is almost ready to leave. Teams may need to look at timely diagnostics, daily therapy input, standardized discharge criteria, caregiver training, and clear communication on recovery expectations and escalation plans. The third primary driver is reliable step-downs transitions to post-acute care. For many stroke patients, acute hospital length of stay depends not only what happens in acute ward, but also on whether the transition to community hospital care, outpatient rehabilitation, community support, or home-based follow-up is timely and reliable. Under each primary driver, the diagram lists secondary drivers and possible change concepts. These are not meant to be a checklist where every team must do everything. Instead, they provide a shared national menu for possible areas for testing. Each team should use its baseline data, process map, and local context to decide where the biggest opportunity lies. Some teams may focus on short-stay pathways, others may focus on earlier rehabilitation association, discharge criteria, caregiver preparation, or smoother step-down transitions. Some ideas can be tested alone, others may need to be tested together as a bundle. For example, a short-stay pathway may require risk stratification, timely diagnostics, discharge criteria, and escalation planning to work reliably. So the driver diagram is not just a diagram, it is a shared theory of change for the collaborative. It makes explicit what we believe needs to change in the system, while still allowing each institution to choose a focused and locally relevant starting point. The driver diagram operates at different levels of measurement and action. That at the highest level, the collaborative outcome measure is acute hospital length of stay for ischemic stroke patients. This is a population-based, system-level outcome measure. It provides policy alignment, supports system accountability, and allows national monitoring of progress. However, individual teams should not only focus on a system-level outcome. Length of stay is influenced by many factors, and a team may not see immediate movement in the outcome measure after 1 or 2 PDAC cycles. This is why teams also need service-level outcome or output measures. These help teams understand whether their local service performance is improving. For example, teams may track whether disposition decisions are made within the intended time frame, whether diagnostics are completed within target turnaround times, or whether rehabilitation referrals are initiated earlier. At the department or team level, process measures become especially important. These measures tell teams whether the redesigned workflow is being carried out reliably. Examples include proportion of eligible patients assessed for short-stay pathways, the proportion receiving early therapy review, or the proportion discharged with clear escalation advice. Finally, teams may also include clinical, functional, or experience measures where relevant. These help ensure that improvement in length of stay does not come at the expense of patient safety, recovery, or patient and caregiver experience. The message for teams is simple. Use the national driver diagram as the shared map, but choose a focused part of the map for local testing. Select the drivers and change ideas that match your local problem, then build measurement strategy that includes outcome, output, process, and balancing measures. This is how the collaborative connects national accountability with practical frontline improvement. The National AVBC Stroke Collaborative is ultimately about improving the system together. Each institution starts from a different context, but the shared aim is the same: to improve care reliability, reduce unwarranted variation, and support better patient journeys for ischemic stroke patients. Thank you for being part of this national improvement effort. This initiative is proudly brought to you by the National Improvement Unit Singapore in support of appropriate and value-based care.